Hi. Hello, everyone, and thank you so much for joining the context session that is focused on CMS Access, the new outcome-based model focused on chronic care. And we are here to talk about uh, this model and things. But I think before that, what I'd like to do is have a quick round of introductions and get you to meet our esteemed panel. I'm Sandeep Mantri, Vice President and Senior Partner at Innovaccer, working with our customers across provider and life sciences. And with me, I have here Sam Hiatt, who is part of community care of North Carolina. And maybe Sam, you can just quickly, do a quick introduction of yourself.
Yeah, absolutely. Everyone, I'm Sam Hyde. I'm the Director of Medicare Program Operations at Community Care of North Carolina, or CCNC. I run our care management operations for our Medicare patients, Medicare and Medicare Advantage. So excited to be here and talk about this.
Thank you, Sam. And Lisa?
Yep. Hi, everyone. Lisa Bari. I'm the Vice President of Policy and Partnerships here at Innovaccer. And prior to Innovaccer, I also worked at the CMS Innovation Center on primary care payment models, on health IT, interoperability, and AI issues. So I've got a view on the CMS ACCESS model and other similar models, as well as a perspective from here at Innovaccer.
Thank you. Dr. Govil, last but not the least.
Hi, everybody. Ashul Govil, nice to meet you all. I am the Medical Director for Story Health. We are recently joined Innovaccer family last year, really the part of Innovaccer that delivers clinical care on behalf of patients for chronic disease. So obviously very much in tune with sort of the work that ACCESS does. I'm a cardiologist by background, but I've been working in sort of the technology care world, as we call it, for most of my career, really trying to figure out how we can help deliver care through asynchronous and virtual methods. And we'll share some of that with you today.
Perfect. Thank you so much, all three of you. Glad to have you here. And Dr. Govil, that was a great segue, right? So I think, obviously we're here to talk about the CMS Access model. CMS has learned over the last 15 years on what to put in place to move outcomes. While this is a patient-centered chronic care model, it is different from some of the traditional, pop health models like MSSP, MA. One of it being, that it is per patient outcomes based and not based on reimbursements, based on the entire population necessarily. And what that has done is, and this is by design, I think what that has done is that it is sort of, since it's tied to individual payments of patients, it is allowed tech-focused organizations and direct-to-consumer companies to become CMS Access participants, right? So I would even say that, what you were talking about, Dr. Govil, in the last part of your introduction was it's even geared towards AI-led care delivery a little bit, especially because of the way the finances have been set up, right? But just to sort of bring it back to what we're here to talk about, because it is designed to be for tech-focused organizations and direct to consumer, there is a risk in patient-provider relationships when it comes to health systems, right?
Yeah.
And I just wanted to set the context for everyone that today's discussion here, or the fireside chat, we didn't want to get into the mechanics of, the checklist of being a CMS Access participant or necessarily the details of the operations. But we wanted to talk about this sort of risk, right? And, why you should have a trusted and reliable partner, a partner that can, A, protect the patient relationship for you, B, meet the outcomes, and, C, ensure that the providers are getting all the information about their patients and not losing any of it, right? So that was the context of this this conversation or fireside chat, right? And since you were talking about Dr. Govil about this, let me start with you. I think some health systems are looking at access as a reimbursement opportunity, but maybe they should take a different lens and look at it. Like, what are the organizational requirements, and what does the model actually require? So maybe we can start there briefly and then get into the partnership that I was talking about.
I think one of the goals of Access, not to speak for the people who created it, but if we really think about why does it exist, why was it put into place? As you said, I think there's a recognition of two things. One is we really want to have our healthcare delivery systems really be aligned with the outcomes of patients, and I think that's something that we've always wanted for our healthcare systems in this country, and we've done a pretty good job of that. But then at the same time, the second requirement is we want to do it in a way that's sustainable and cost effective. And I think one of the challenges for CMS for the last few decades is creating those programs that can treat the populations that we need to treat, get them the effective outcomes, those, whether it's controlling the blood pressure or the diabetes, but doing it in the context of a sustainable system where the costs aren't just out of control, right? So that's kind of the background I think this is all being deployed in. And then I think in the last couple of years, and maybe the pandemic was kind of the key sort of thing that really caused people to realize, hey, we've always required patients to come into the office or to come into the hospital or the ER to get their care delivery. Face-to-face visit, these encounters where we have our traditional sort of fee-for-service billing based on when we see patients, what we do for patients, we do procedure on a patient. And now all of a sudden, with the pandemic, everyone was moving towards telehealth, and we can use technology in health care in a way that we about before. And so for the last 7 years of technology in a way to deliver that same care we've been delivering, maybe even in new ways, but do it in a way that's cost effective. And I think that's the reason they really want to bring in, they want to force people to bring this into chronic care management of patients. The challenge, however, is any organization that wants to participate in Access obviously has to have the capabilities to actually engage with patients using technology, both with kind of platforms, the engagement, but also a new care model that's going to be required that is a little bit different than our existing ambulatory care model today, right? I think most of that episodic care model we have based on clinic visits, based on encounters, based on procedures, moving from that to this more asynchronous, continuous relationship with patients while they're at home, I think is going to be a challenge.
Got it. Makes sense. Sam, Lisa, anything to add? Otherwise, I have a follow-up question sort of that ties into this.
Yeah, the thing that I would add is really around the design of the program with the fee-for-service exclusion in particular that really locks out a lot of the traditional healthcare services that patients are used to with brick and mortar. So when I look at the design of the program, it really is designed to be tech forward and bring more technology, more players into the market, I think, is what CMS is looking at as well, to hopefully enhance outcomes, drive outcomes in a sustainable way, to Dr. Govil's point.
Yeah, perfect. I would just say in the follow-up that, it is not that the model requires the company, the participant of the model to be tech only or AI only or anything like that. It's just literally that you are excluded from billing fee for service. So it makes it, probably not very attractive to most more traditional in-person settings. So you don't have to even use technology in any meaningful way beyond data sharing via standards-based APIs, but you do have to restructure the way you operate, and that's only going to probably make sense for sort of those folks who are technology first players, I would say.
Yeah, I think the reimbursement really to some extent does force that.
Yeah, definitely.
Yeah,
I think that's a great point.
Certainly does.
Like most programs in the past have really focused on, we'll pay you more in the first couple of years and then drop the payments eventually. Obviously with Access, they have a very different approach where even if you're willing to forego the fee-for-service payments, if you have a value-based sort of part of care delivery that you're delivering right now, the amount that's being offered through Access requires you to really think about the resources and how you're delivering care, right, in a much more efficient way, just because those payments are much lower.
Absolutely. But I think Lisa, given your sort of background, so whatever you and Sam and Dr. Govil just mentioned, and I think you sort of gave the color of what technology from a health system at least they need to have. It doesn't have to be the way we were portraying it necessarily. But do you think CMS still, if you look at it, CMS has sort of opened it up to tech and care delivery organizations that have both, right? Is that sort of intent? Like, was it intentional? And what does it mean for health systems and their relationship with their chronic care patients?
Yeah, I think it was definitely intentional, and it comes out of a history of how tech-enabled care makes its way to Medicare beneficiaries or other folks who might be affected by some of these innovation models, these value-based care, innovative payment and care delivery models. And in particular, accountable care organizations and also Medicare Advantage plans have had in Medicare Advantage, generally two options, right? You can be an original Medicare fee-for-service Medicare, you can be a Medicare Advantage with a private health plan. These folks have had, MA in particular, has had a lot of flexibility about how they deliver that care and using new tech-enabled tools, digital health tools. Got one on my wrist right here, for example. Just things like that, right? Or but the things that we use with Story Health by Innovaccer, or maybe more of a medical grade, but just different options for how technology is brought into some of these care delivery mechanisms. And MA has had a lot of flexibility, and then accountable care organizations have really tried to bring in some of those tools as well. They've had a little more flexibility too. And so this is really just an acknowledgement that there is we need to continuously figure out how we can better bring in technology into the delivery, into innovative care delivery, and where we're trying to specifically improve outcomes and improve quality and reduce the cost of care. And so there's already been a lot of work that's been done, again, by MA and by ACOs. And this is, I think, trying to sort of formalize that into a more structured experiment. And importantly, which I'm sure we'll talk about as well, is, and Sam already mentioned it, is the reimbursement rates being quite low. Having spoken to Abe Sutton, who heads up CMMI, and Jacob Schiff, who's in charge of some of their AI initiatives and really was leading a lot of this model, and other folks who were instrumental in creating this model and getting it to this stage of being about to launch, is that they really, really, really wanted to focus on reducing the cost of care, bringing technology in a way that is deflationary, and so they worked really hard to get those rates as low as they possibly could, not just for the sake of having low rates, but because they needed it to be something that they believe can scale, that they believe will be able to pass the test that CMS has for this, which is the CMS actuary has to say, did this model actually improve the cost, reduce the cost of care while improving the quality of care and improving outcomes, or did it just cost us more money? And so they are really focused on trying to prove that out. And these rates are a result of those really complex actuarial calculations and what they can predict at this stage. So it's both building on work that's happened before and also really trying to move that forward by keeping those reimbursement rates very focused on technology-enabled care. So it's not like it's the first time a Medicare beneficiary has ever been exposed to this or ever seen this. It's not the first time at all, but this is a pretty meaningful and specific step forward for this type of care, I would say.
It's pretty interesting, I think. Sorry, go ahead.
Oh, and I was just going to jump on what Lisa was saying. I think it's really interesting that they're thinking about it that way, and what it'll force, I think, the technology companies to do, right? So when you're working with fewer resources, you're going to have to innovate to figure out how do we actually achieve the clinical outcomes we're looking for, but also do it in that kind of cost context that Lisa's talking about. You really can't do it today with there's just a sensor on your wrist is not enough to actually say, okay, let's manage this person's blood pressure and change their medication and do everything that needs required, order all the lab testing. You can't do it today. So it forces, I think, innovation as well. So it's not just about, oh, you have to work with this cost model and deliver care in a traditional way. You also think very carefully about how to interact with patients, how to get them where they are, but still enable them to achieve what we want them to achieve. So it's a very different way of thinking about patient care.
And I think one of the things that Lisa was saying, it's an experiment, but it's based off of what CMS knows for a long time. Ultimately, while these are outcome based per patient, these sort of measures or the structure they've put in place is also aligned with the HEDIS measures, the sort of like the long-term accountable care population actually is going to get better, right? So it's that experiment word, Lisa, is pretty interesting, right? Like this model could either just complement or probably long-term down the line sort of not entirely replace, but sort of I just was curious in the thoughts that you guys have around that, if any.
Yeah, I think that's a great point. One of the really good things is you brought up the actual outcomes that the aligned payments are kind of geared towards. And those outcomes are directly, you can kind of do a one-to-one matchup with the aligned payments for access and those that are used in HEDIS measures, those are used in STARS ratings, right? Kind of across the board, when you look at the quality metrics that we look for in value care, whether it's a hypertension goal, an A1C goal for diabetes, they're looking at, behavioral health, and are we actually using standardized tests for depression, for anxiety, and making sure we're getting those numbers down, improving those outcomes. Those are all the exact same things that we're already using. So it actually is really interesting to think that you can benefit with other programs we'll be running because these patients can be multiple populations. So you're already going to be able to influence the care in other parts of your organization by really thinking about participating in access or having your patients participate in access. That's number one. But I think you bring up a really interesting point, Sandeep. Is this eventually going to be a transition, right? If this works, are they actually going to be transitioning more and more towards an access model and pushing maybe some of the traditional programs CMS has used in the past, pushing those patients out into access? And then it really makes it more important for any provider group or health system to be really thinking about enabling this early on. Get that experience.
Yeah, and I think to that point, I'll throw a question to Sam. Both within your organization, Sam, and others that we have had conversations with, physicians. Firstly, physicians are always things are done to us sometimes, as opposed to keeping us in the loop. And secondly, the health systems and larger organizations and larger practices, like when I started the sort of discussion, right, are also thinking that they could remain passive, right? Because, like you said, I think you mentioned that fee for service, you can't directly participate because fee for service dollars go away.
Absolutely.
So, I was wondering what your thoughts were on how they should approach it, whether with a partner or how that should be done.
Yeah, and I think what we've already been talking about this whole time really highlights how hard access can be. So it really does come down to you have to have a strong clinical operation, which I think CCNC, we've done a good job at. We've been doing it for a long time, with the Medicaid population and expanding into the Medicare population. But you have to combine that with technology. You have to combine that with logistics as well, with some of the requirements for remote patient monitoring, things like that. And you have to be able to deliver all those things at scale and with a lot of precision if you're going to be successful in access. And so being able to meet all those criteria is very challenging. And being prepared on day one, because day one is on 7/5 of a week and a half away from today, is very, very tough. So when we looked at access, it really came down to what are we good at and what things should we focus on and where can we partner to really hone in on the things that maybe we're not wanting to focus on or we're not traditionally built to focus on. And so that's really where kind of that traditional build by partner decision kind of comes into play. For most health systems, you can't build or buy because of the fee-for-service exclusion. So it really comes down to a partnership perspective or just not participating. And I think the risks of not participating are high. We have, I think, over 200 applicants to participate in the ACCESS program now. And as a organization, we want to have a level of control over, who is engaging with our patients, how are they engaging with our patients, and how are they being transparent with our practices and our providers? How are we working together to make sure these outcomes are happening and they're not happening in a silo that may be impacting downstream? How are we controlling overall cost of care? Because, for many of us, we are accountable for total cost of care for these patients as primary care providers. So there's a lot of things that you really need to think about when you are making that decision of, are you going to partner? Are you going to participate? Or are you just going to kind of hang back and see what happens? And so for us, being proactive was really important in our evaluation of the program, making sure that we, vet partners that are going to align with our mission, vision, and values, that are going to be able to deliver on that. And then at the end of the day, our providers are our bosses. Our MDs and DOs and APPs are our bosses. So we need to make sure we're delivering value to them and making sure that those partners are delivering that value and controlling those other items. And I do kind of see it as both a defensive strategy of how do we protect our patients and our practices? How do we build a moat to make sure we're not losing attribution? We're not losing those fee-for-service dollars where patients are being routed elsewhere. But I do see an offensive component, and coming from value-based care ACO background, I see there's an offensive component of this as well. The end goal is that we are improving outcomes and lowering cost of care. So the offensive piece will be more long-term, saying, hey, if we have patients participating in ACCESS, is that helping us better control our outcomes in our ACO contracts? And will that, really make us stand above others that are not participating with an ACCESS partner? So definitely to start off with, we're thinking very defensively, but, thinking long-term, I do think there's an offensive component that can really complement the contracts that you're in with your payers and your plans.
Yeah, wait, can I just follow up on that quickly? Because I think also, Sam, as you mentioned, there's probably 200 plus participants in the program, and none of us can tell any Medicare beneficiary what they can do, and this Medicare beneficiaries have their choice. At the same time, people learn about this very often through their primary care physician or provider. And so when you say, like, we want to take ownership of it or take a little bit more of control, can you say more about what that might mean? Not specifically to tie CCNC to anything, but to say, what would that look like for a health system or an ACO to say, we're going to lean in on this one?
Yeah. Well, I think the first piece is just education, and really surveying our practices and providers. There's still just not a lot of knowledge around ACCESS. And so getting education out there saying, hey, it is coming. Here's what it is. Here's what to expect. Here's the questions that your patients are going to be walking through that door with when they come to meet with you. And then, here are the organizations that we would say would be a good fit for you to partner with if they ask that question. We do expect there's going to be a lot of direct-to-consumer marketing. Looking at the applicants, they are very, very good at direct-to-consumer marketing as well. So making sure that we have those answers ready to go for our patients. And again, maybe even being proactive. Maybe a patient hasn't seen the Facebook ad or an ad wherever for an ACCESS participant, but saying, hey, you have these conditions. I really think this would be a good fit for you. That way I can keep a better eye on your blood pressure at home, or, we can get you a home blood pressure monitor that's going to report directly. And this organization is going to make sure I get every one of those readings. And I can also keep a close eye on that to make sure we're meeting our targets. So that's where the complementary aspect comes in. And I think a big part of our evaluation for ACCESS partners is that collaboration and transparency, not replacing the PCP relationship, enhancing the PCP relationship, and making sure that, everything is above board and we're all communicating together and we're working together at the end of the day. And that's where I see that, it could be that it really improves the PCP patient relationship. But there is the risk. There is the risk of it disjointing that relationship, and that's what I think a lot of us are very concerned about, is those that may operate in a silo.
Yeah, Sam, it's interesting because when I go to the hospital and I'm talking to my colleagues there, 10 years ago, they had their competitor across the street and maybe a guy across town they had to worry about. And now all of a sudden they have, people sharing their medical data with, the Googles of the world or the Open AIs or, whoever's got whichever band you're wearing there, Lisa, right? That's there's so many more ways to lose the patient and their attention, and patients are seeking out new ways to get their care too. So if they're not being proactive about it, if these primary care doctors or the specialists are not going out and seeking, how do my patients want their care delivered to them, and how can I be a part of that? There's a real risk of that kind of fractured care that you're talking about. It's a real.
Yeah, I was just checking. My app is talking to me right now about, I was like, what is it telling me to do? It's certainly, and this is totally disconnected from, my primary care provider, and who knows where all of these things go. There is always a real risk of disintermediation. And I think, at least certainly in my opinion, it sounds like we all generally agree that, if health systems, if providers, if ACOs don't lean in, there is certainly a risk here. It may not happen on day one, but, assuming everything here continues as it's planned for 10 years, right, and continues to grow, that disintermediation will probably get very real.
Yeah. Well, and Dr. Govil mentioned earlier, and, I'm a pharmacist by background. I've done chronic care management, advanced primary care management. I think clinically as well, they're not going to have the same view as a primary care physician. While it is designed to be complementary, again, if you're operating in a silo and you're only focused on these strict conditions that you're accountable for, what does that look like from a PCP taking a holistic view when we're not working together? You don't have that level of control over the relationship. Sorry. So, yeah, I think from a clinical standpoint, the risk is real, but then the benefits are real as well. And making sure that patient, you've been struggling with their BP for 10 years now, you cannot get it under control, but giving them more control over controlling that condition, hopefully will get them to that goal.
Yeah. I'm gonna jump on that clinical path. I know most of the audience will be bored if I talk too clinical, but it's important, right? These patients, we're talking about real disease. There's high blood pressure, there's diabetes, which sometimes we don't think about as being serious disease, but these are the diseases that lead to the heart attack and the stroke downstream, right? And if you have, I'm not going to name specific companies, but your weight loss team that advertises you on TV, if they're the ones managing your diabetes medications, your weight loss medications, well, when something does go wrong or you have a concerning symptom, what's going to happen? Who are they going to refer back to? How are you going to get those tests done to see if you are at risk of a heart attack or something bad happening? If you don't have that connection back to the primary care, to the provider, there's not only a risk of that disjointed care and losing out those patients, but I think for the patients themselves, there's a risk too. So it's just the right thing to do for patients, frankly, to make sure that they have that connection back to you.
Absolutely.
Makes sense. I think so. One of the things that I wanted to ask the panel is how do we go about that education, right? Because we have talked at length, and I've from my experience, what I have at least in the last few conversations that I've had with our existing customers and otherwise, is that health systems are receptive to the idea of partnership and understand, especially because they can't do it themselves. Physicians, that's where I think a more clearer education needs to come into play. And maybe Dr. Govil, you already touched upon that, right? I think that the thing that you were saying, that it actually impacts patients and their lives, and maybe that's the way to go about sort of informing the physicians, right, and the physician leaders, because sometimes different questions come up as to how will I get the information back? And I don't have the capacity. Will this increase referrals, or will this sort of reduce referrals to me, and will you take care of all of it? So I think my question to the panel is, what are the things that physicians should, sort of think about when they think about this program, and not just the health system or the ACO as a whole?
Yeah, I can jump in to start off for sure. And I think we've already touched on many of these items through our conversation. But again, just tying it back to, this is focused on improving your patient's outcomes. It's focused on getting ahead of the progression of their disease. It is not designed for an end-stage renal disease patient. It is designed to catch them when they're at CKD 3A, 3B, before they get to that point in time, and halt the progression. And all the physicians I know and I work with, that's their goal as well. And so making sure that they understand that at the end of the day, the goal is improved outcomes, getting them into you sooner before they reach these points where their health outcomes are just on a downward trend. And I think all of us want that for ourselves, for our families, for our patients. And that's the goal of the program. And it is going to be innovative. It's going to force us to deliver care in different ways than we're used to, which can be uncomfortable, but we have to be okay with being uncomfortable. It is kind of a adapt or die. We have to really rise to meet this moment of ever rising healthcare costs and ever aging population. And we have to be able to scale our care delivery models to be able to handle that. And this is an attempt, hopefully a successful attempt by CMMI and CMS to be able to deliver on that.
Yeah. And Sandeep, if I'm hearing your question correctly, it's, as a physician, as a provider, as a clinician, what should I be thinking about, right? And to me, it requires us to think about my role as a primary care provider a little bit differently. I think historically, we've always relied on primary care providers. I've always heard them described as quarterbacks, right? They kind of get the ball and they hold on to it until they find a need to pass it on to someone else, right? This patient's getting too complex. I need to send them to a cardiologist. They're getting too complex. I need to send them to the surgeon. But they need to flip that thinking a little bit. I think that still applies, referring to the specialist when patients get complex. But there's also this idea of 30 years ago, maybe 40 years ago, patients had one or two problems. They don't come with a list of 12, 13, 14, 15 different problems. You can't take care of it all. So what can I offload, even if it's a simple problem? Maybe it's too simple for me as a primary care doctor. Maybe I don't need to waste this, clinic visit here to just go up on someone's blood pressure medication if they're otherwise doing okay, and I can instead concentrate on this other big issue that they do have, right? So this is also an opportunity, I think, for clinicians to rethink the model of referrals, to say, let me refer out for things that I think a partner could help me with. And as long as I'm monitoring it and, I'm getting that data back and I can be involved, I don't necessarily need to be directing care there because it's relatively straightforward. And as long as my partner can control it, great. And if they can't, well, great. Now I know about it and I can refer on to that cardiologist, or I can take care of it myself when it doesn't become more complex. So it's flipping that thinking around a little bit of how you manage care.
Yeah, I would just add that, maybe 20 years ago or more, we might have said like, Medicare populations, they don't know how to use a smartphone or a device. That is not the case anymore. We have long passed that moment where, people who are 65 and up certainly are using lots of technology, consumer technology, medical devices, smartphones, you name it. And so that is not an accurate statement anymore. And so, far be it from me to tell medical doctors what to do, but I would just say, you know what, your patients, they are using these tools, they have these devices, they are using their phones. And so what can we do, all of us in the healthcare system, to meet patients where they are? And this is just like you said, this is a credible and important and meaningful attempt to do that while also finding a way to, we hope, support these total cost of care initiatives as well, right? By carving out a piece that we can define with really specific outcomes that should ultimately help with health status and also improving those total cost of care numbers as well over time.
Perfect. Thank you. I think I'm getting prompted by the chat that there might be two questions from the audience. I just wanted to touch upon one last topic. When I started the introduction, was talking about, AI-led, little bit about what components or what does that mean? It doesn't mean that, it's an AI is a doctor. So it's just, just to ground it to what it means. And, it will add value in the sense of making it feasible to do all of this, but it doesn't necessarily mean like a AI doc is, taking over. So yeah, open to Sam, Ashul, Dr. Govil, Lisa.
Yeah, I mean, I'm happy to start, and then would love to hear the rest of you guys. But I think AI-led care is, you're right. It's not AI is replacing the doctor and making medical decisions, right? Maybe in 30 years, maybe our kids will have that. I don't know. But for us at least, and for the Medicare population today, what it really means is how do we create access for patients who don't have it today, right? Even if a patient has a primary care doctor, even if they have 2 specialists, do they really have full access to the care when they need it? When they're sitting at home and they don't looking at their pill bottles and they're confused about what to take, who's going to help guide them? It's hard to call up the doctor's office and get that guidance, right? But there's a huge opportunity for an AI nurse to take a look at those bottles, or here those bottles are and here are the concerns, here are the questions, answer it, or if they can't answer it, then to forward it to their primary care, to forward it to a nurse, a human nurse who can. So there's this extra level of sort of intervention and opportunity to educate patients and interact with them more frequently, when otherwise I think we're just dropping the ball and we're just not recognizing there's an issue today. I think that's what it's really about. It's really about accessing newer barriers to care is really where AI is going to tackle things first.
Yeah, we don't really have time now to go into a ton of depth, but for folks that are interested, we can certainly talk to you at Innovaccer about adaptive program intelligence and how Story Health by Innovaccer works, how our access solution works. But I think fundamentally, one way to improve quality and outcomes is to follow defined care protocols that are, best in class, that are, that are validated by leading physician and specialty organizations, by primary care doctors. And so one of the things that we can do with automation is make sure that we have these, really validated care protocols being followed. And like Dr. Govil just said, making sure we increase access, not access as in the model, but access to care throughout, because literally, no matter which way you slice it, there are not enough physicians or clinicians out there for all the people, even just Medicare beneficiaries who are eligible for this kind of care. People who, have some of the cardio, kidney, metabolic, or musculoskeletal or behavioral health conditions that are covered in the access model. So I think even if all we did was just simply follow validated and high quality care protocols and gave access to people through that, we would make a difference. And luckily we can go beyond that, but even just following those quality protocols would be really fantastic for the pod. That's my take on it, at least. Sam, I'd love to hear your thoughts, but that's how I look at it.
No, I fully agree with you. And I think the piece we haven't touched on is people are already using LLMs to research their medication and their conditions and putting in their symptoms every single day. So it's happening whether we want it to or not. And so again, it comes back to how do you insert a level of control to make sure they're getting the right information back. So we're not harming, we are helping patients, and hopefully Access helps give them access to those robust models that will give them the right answers, but also has a escalation pathway that a regular LLM doesn't have. So, hey, this is hit my guardrail. I need to get a human in the loop. I need to get a human involved with this situation because it is escalating outside of where I should be providing consultation to this patient. And so that's the piece that I think will also make a big difference. Is it's already happening. So how do we stay ahead of it or try to get ahead of it?
Great.
Perfect. I think with that, thank you so much. Let's open it up for questions from the audience. So I think you might have addressed it, but
I can
the
answer
question
this.
is,
I can answer this one if you want. Go ahead.
Go ahead, Lisa.
So the question is the fear that access vendors will enroll patients directly. Yes, that is in fact something that may happen, right? The CMMI is not restricting Medicare beneficiaries from, signing up with a participant of access who could be a technology vendor, a company like that, or a device company. This absolutely may happen. I do think it's going to be a relatively slow start. There's a lot of education that needs to happen, and I have not personally seen any direct to consumer, direct to patient advertising yet. That doesn't mean it's not happening, but I've not seen it out in the market. The model doesn't start until July, so we're almost there, a few days, but certainly it's happening, and it is likely to happen. And what we recommend, this is very sort of an Innovaccer perspective, and I think Sam kind of pointed to this too, is being intentional about the partnerships that you close that you can then use to help educate your own patients, your own Medicare beneficiaries, your providers, your physicians, your clinicians, your staff, about partnerships that are what that would make sense for you and your organization. And you can't stop anybody from signing up, but you can help provide that education for something that might make more sense for you and your organization. That's my take. Anybody else want to jump on that one?
No, I agree. I agree with everything you said. I think it's going to start as a trickle at first. When July 5th rolls around, I don't think it's going to all of a sudden everyone sign up for access. But as the program grows and as they refine their marketing algorithms to get the right targeting out there, I do think there's going to be more and more participants. So again, just staying ahead of that and making sure that your providers, your staff are educated, your patients are educated, so that you can maintain that relationship with them long term, and you can protect your patients from potentially, hopefully not, but potentially bad actors in the market.
Yeah.
Perfect. It's a good segue to the next question, which is, how to evaluate if a potential access partner is actually aligned with your clinical model and your population. So Sam or Dr. Wool.
Yeah, I can take this. We're actively doing this right now, and we're involving our physicians in that process to make sure that they're fully aligned with it as well. So I think it really does come down to, for us, is the transparency and collaboration. Is it happening? Is it proactive? Is it consistent? How are we not operating in a silo? How are we working together in order to take care of this patient? That is the key critical priority for us, is that level of transparency between the access organization and our practices and providers, is just making sure that's happening and happening consistently. I will say there's also an education component that the PCPs or the referring physicians are paid $100 annually. So how is that also being communicated? We want to make sure that, for their time in working with these participants, that they are getting reimbursed for that time and reviewing those notes. So that comes down to us educating, but also hopefully our vendor partners also educating the practices on that as well.
Great. Yeah.
Wonderful. So I think we are almost at time. I just wanted to leave with one parting thought, to distill this all down, that obviously, this is going to be hopefully good for the patients, as the panelists were speaking about. CMS has had experience, and that's why they've come up with this program. But I think the organizations that will sort of win in and provide the best care for their patients are not the ones that probably have the most number of resources, but probably shape how their relationship with their patients will continue to look like. And I think in our opinion, that definitely needs a good, trusted, reliable partner. The thing with what Lisa was also saying, that the beneficiaries can enroll directly. The question that was there regarding, will tech vendors just go and enroll members or patients directly without keeping the physicians in the loop? So, you have to think about it actively as a practice and as a health system. Otherwise, it'll sort of happen with or without you. So that is the last thing that I want to sort of leave the audience with.